This is Rory Spiegel and Ryan Radecki, and this is the Annals of Emergency Medicine, October 2025. Ryan, how you doing?
Not too bad, although we are under a red wind warning today.
Oh, yes. Since this is take two, I already know that a red wind warning has nothing to do with the color of the wind, but rather the speed of the wind.
Where is it that there are colors to the wind?
I don't know. I thought maybe it was like a sandstorm, like red wind,
Sure. Kids are actually home from school today because of the threat to life and property.
Yeah.
So my city is under a state of emergency today.
The listeners can't see this, but I can see your head in a room, and behind you there's a window, and those trees look very still out there. It doesn't look like there's any wind actually happening.
Yeah, that's why we're doing it now. Well, we still have electricity. So the wind's supposed to hit in an hour and a half.
Whoa. Okay.
Yeah.
All right. You'll have to keep us updated. Oh, I see a little wind. Actually, things are starting to move. Oh boy. Okay. I'm going to be mesmerized this whole podcast of the trees out back and getting an idea of your wind.
And all the listeners can live vicariously through your visual.
I will let you guys know if a branch comes right through that window. But we should probably get started before you lose power or there's your head.
Dramatic branch events.
And so our next article is actually a very interesting one. The incident and clinical relevance of echocardiographic visualization of occult ventricular fibrillation, with the lead author being Romolo Gaspari. This is an interesting topic. In cardiac arrest, we have very few actual treatments that make meaningful benefit to patient outcomes. That's why, for the most part, most literature suggests that cardiac outputs have dismal outcomes if you don't have two factors that are done effectively. One is CPR, most importantly, bystander CPR, and early defibrillation in patients that have ventricular fibrillation or another shockable rhythm. So for a while now, there's been discussion of what's called occult ventricular fibrillation, or this idea that patients have ventricular fibrillation. It's just so fine that you can't see it on the monitor. And if you could shock them, you could transfer them from an asystole patient who has dismal outcomes to a VFib patient who has much better outcome. The data on this is not very strong, mostly because we don't have a lot of it. And so these authors, what they did was essentially a multi-center prospective study across 28 EDs in Canada and the US from 2021 to 2024. And they took patients with out-of-hospital cardiac arrest who presented to the emergency department, and they looked at the ones who had simultaneous EKGs and echocardiography done during one of the first three pauses of CPR. And during this, they each were recorded independently. Now, the treating clinicians could use both and decide what to do with them as they wanted. But these recordings of both the EKG and the echo were recorded and then presented to blinded emergency physicians and two cardiologists to basically decide whether they were having ventricular fibrillation on the EKG or ventricular fibrillation on the echo. And then they looked, their primary outcomes was the incidence of occult VF, which was defined as visible fibrillation on the echo, but no shockable rhythm on the EKG. Secondary outcomes was essentially looking at the rates of ROS, survival to discharge, termination of VF in patients who had occult VF versus patients who had VF that you could see on your EKG. They screened over 1,000 patients, and then they got about 811 patients that had both recordings of their EKG and their echo. And what they found was occult VF was fairly common. About 5% of patients, 43 patients, ended up having occult ventricular fibrillation. So found on the echo, but not on the EKG. And then 202 or 24.9 had traditional VF. Now, here things get a little interesting or questionable. When they talk about this, they said 81% of the patients in occult VF had PEA on their EKG, with only 19% in asystole. Now, I don't know about you, but I can't really think of a way physiologically that one can have PEA and also be in occult VF. And so even here, you start to question what were they actually looking at with these two things. When they look at the agreement between the clinicians who were evaluating VF on an echo, it wasn't great. The kappa was 0.65, which is okay to moderate agreement, better than chance alone, but certainly nothing spectacular. And then when they looked at outcomes, essentially it looks like occult VF does as well or maybe a little better than patients with true VF. Termination of VF aftershock was 75% in occult VF, 55.6% in true VF. ROS 39.5% in occult VF, 24.8% in true VF, and then survival to discharge 7% versus 5.4%. So overall, I think this is an interesting issue. I think it's probably less positive than these results initially appear. One, you have to remember this is refractory cardiac arrest. These are the patients who make it to the emergency department after they've already had quite a number of rounds of CPR. Many of these patients, when they first presented, weren't presenting in VFib at all. They are presenting in a PEA arrest. If you look at data on VFib, when patients go into VFib after they've already been in PA or asystole, the outcomes are far less good than if you were in VFib when you initially started. And you can see this here with the survival to hospital discharge in these groups, right? 7% versus 5% is not what you usually see when you're thinking about people in VFib arrest. Usually, when you look at cohorts of out of hospital cardiac arrest with VFib arrest, survival is at least 20%, sometimes much higher, depending on the rates of bystander CPR and AEDs present. Then the next question is like, what was the true rate of ventricular fibrillation or occult ventricular fibrillation? Again, the kappa wasn't perfect. What's going on with these 81% of these patients being in PEA while being in occult VFib? Those two things don't match. And so either the PEA was wrong, meaning there was some noise on the monitor or something else gave what appeared to be PEA, or the reading of the ventricular fibrillation was wrong. And so it's hard to know exactly what to do with it. I think in the end, it's something to think about, like in a patient who comes in, just like, you put the probe on, you rule out pseudo PEA, or the patient really has a heartbeat, you rule out pneumothorax, you rule out some fixable causes. And if you see VF on your echo, you can shock it. I wouldn't make as big a deal of it as I think this says. Like, I think most fine VF, we know, the outcomes of fine VF versus coarse VF. Coarse VF is what we typically see. Coarse VF has much better survival. As an arrest goes on and the VF is going to be going on for longer and longer, it becomes finer and finer. And with it, the outcomes become less and less viable.
I think it just means that you got to shock all asystole. I think that's the lesson here.
That's not what this is saying, right? 81% of them had a PEA rhythm. What do you do with that? Do you shock all
Well,
PEA?
like you said, none of this is reliable. Neither the people reading the electrical heart rhythms or neither the people reading the echocardiograms. So, just to be on the safe side, I think ACLS should be rewritten and that
To
everybody
shock
gets a
everything.
shock up front, whether it's in VF or who knows what, because clearly nobody knows. But I mean, you can see like there's a whole separate thing. Like the people treating the patient did their thing, and they just they treated it the way they thought it was based on the echocardiogram, and then they had like all the cardiologists doing an ECG review independently, and then an echo independently. So you can see how they ended up like with these like people who were totally removed from the clinical care reading ECG and VF, and then having that discordance there. But I mean, obviously that discordance is like the core of this. It's like this is not we can't reliably measure this and evaluate this in the clinical setting necessarily. And then you say, do you just like ignore the fact that we're missing some VF, or do you just shock everybody?
Yeah, I mean, in my mind, I think like fine course or occult VF is more a marker of like prognosis in a study like this. Like the patients did a little better, and as you said, this didn't mean they were guided by this occult VF. The clinicians did whatever they wanted, and a patient in occult VF probably was down for less time, had a little more bystander CPR, just had a few more positive prognostic markers than the ones that weren't.
As I think the end result is nothing should change clinically based on this, but it's
Yeah.
an interesting thing to uncover that there is this occult VF, obviously, and now we just have to find a better way of picking it up and incorporating it and seeing what kind of results we get from treating it.
Apparently we have to do a better job with our monitor leads, right? Because
Well,
81% of them should not have been in PEA arrest.
it was picking up the bed. I don't know. They got dislodged during CPR. Who knows?
Yeah,
Who knows? Like CPR is, it's chaos to some extent
yeah,
sometimes. So
yeah. I mean, you can imagine like 20%, but this was the majority of them. Anyway, moving on. Our next article: Association of Early Non-Invasive Cardiac Stress Testing with Acute Myocardial Infarction and Mortality, and the lead author is Aniket Kawatkar. All right, so this is an article. I thought this was settled a few years ago, but back I remember when I was a resident and you were a resident, there was a lot of angst about taking someone who came into the emergency department with chest pain and discharging them without them getting some form of stress testing,
this
right?
is a
Because
long time ago that we were residents, by the way.
It's not that long ago, but yes, yes. It's about as long as when this article was done, 2015, right? And so, but the idea was we could rule out an MI, but we couldn't rule out this disease called unstable angina. And if we sent them home, the fear was within the next few days to weeks, they would ramp up and have a heart attack and we would miss it. And so all these patients had to come into the hospital. But since then, we've had many, many studies showing that probably doesn't need to be the case. Yet we still wanted to look at this one more time. And so these authors conducted a retrospective cohort study of a massive amount of patients, over 174,000 patients who presented to 13 Kaiser Permanente hospitals between 2015 to 2020. All these patients had documented heart scores, which we've covered many times on the podcast, but essentially is a decision rule integrating history, EKG, age, risk factors, and troponin. Each of those categories gets a score of a 0, a 1, or a 2. And when you add it up, it puts you in a risk profile 0, 3 being low risk, intermediate risk is 4 to 6, and a high risk is greater than 7. They excluded anyone who had an MI diagnosed during that visit, had a troponin greater than 0.5, again, and basically an MI diagnosed at that visit, that were transferred out of the Kaiser system, had DNR status or hospice care. And they essentially looked at the exposure, which they described as early non-invasive testing within 3 days. And this could either be a stress test, a stress echo, nuclear perfusion, or a CT coronary angiogram. And they looked at patients who did or didn't get this non-invasive testing, and they looked at the rates of death or acute myocardial infarction within 1 year of the ED discharge. So again, they had over 174,000 patients. 61% of them were low risk, so at a heart score of 0 to 3. 36% were intermediate risk, and about 3% were high risk. Now, high risk, if you just kind of start doing the math, if to be high risk in this cohort, because you couldn't really have a spiked troponin, it means you had to have a 2 in every category and then at least a 1 or a 2 on your EKG. So you had to be over 65, you had to have a lot of risk factors, you had to have a really good story for an MI, and then you had to have EKG changes. And so obviously that's a super high risk group. But anyway, what they found is after they adjust for co-founders, they found a significant 1-year reduction in death and MI across all groups. And so for the low risk group, it ended up being about a number needed to treat of 65. So 65 for every 65 stress tests you did, you reduce the risk of MI or heart or death by 1. 20 and a number treated of 20 for the intermediate group, and a number needed to treat of 11 for the high risk group. When they looked into this a little farther, they also showed that patients who got early stress tests also had higher rates of PCI, higher rates of CABG, and then higher rates of starting on cardioprotective medications. I mean, I think the big confounder here is the methods of this study, right? Like, yes, this appears good, but obviously patients who are getting early care is a marker for they're getting a bunch of other stuff, including other medications, including probably less um, complicated medical history outside of their cardiac history, so on and so forth. I think just given the amount of data we have outside this paper showing that early stress tests in the prognostically low risk patients in the ED doesn't change outcomes, basically probably shows this is probably an overstatement.
I think that's the key there is that like the early initiation of all that other cardioprotective stuff, which we know is really useful, or that sort of like intensified follow up, the intensified taking your heart health seriously, like that's the effect here, probably not the actual stress test itself. What this really needs, and I think what would probably put it to bed, is a sham study where everybody gets a stress test, but some of the stress tests are shams. And then they are all sort of in the same sort of idea that they still need to, their risk factors are still getting looked at. They're still getting the dietary and lifestyle modifications, yada, yada, yada. And then some people obviously are getting referred on to, the cardiac, invasive cardiac angiography and blah, blah, blah. And then deciding whether they, and then we could actually see the effect of whether it's we've actually picked up those few high risk people who are going to die, and the number needed to evaluate is like whatever you say, 60, or whether it's just all related to the fact that all of a sudden this person is like freaking out about their heart, and their primary care doctors are freaking about their heart, and they start taking their health more seriously.
Yeah, I mean, if you were to trust the results of the study, this would set us back 10 years, right? Where you get
Set us back 10
I
years.
mean, really, we'd go back because even the hard score threes had benefit, right? The 0 to 3s had
Uh,
benefit. We'd be
a
bringing
lot of them
everybody
did
in.
very poorly in a year. Although there are, I mean, they say that they controlled for the differences, but there are obvious differences in these heart categories between the people who got non-invasive testing and the ones who didn't. Which actually is kind of amazing that the ones who didn't do that well. It's very strange. I feel like the people who don't get invasive testing don't do very well. Oddly enough, compared, it's very strange.
I mean, it probably is a marker of people who are sicker and someone doesn't wanna do invasive testing for other risk factors, so on and so forth, right?
And they are very old to some extent, especially once you get to the intermediate and high risk people. These are like 70 plus people, 70 years old and more with lots of risk factors. I mean, yeah.
Yeah, I think if this study was done, 10 years ago when we didn't have all this data showing that this likely is wrong, you'd probably put a more weight on this, and we'd obviously say, there has to be more studies showing if this is true. But now we kind of have those more studies showing that it's probably not true. That most patients in a low risk group or even the intermediate risk group do just fine without rapid stress testing. And we have enough prognostic markers, mostly our troponin at this point in the emergency department, to safely risk stratify these people into a follow up that doesn't have to happen within the next 72 hours.
When they say stress testing, you were allowed to have a CT coronary angiogram, not just a stress echo or a
Yeah,
stress perfusion. So
yeah. It was any
it's
kind
not
of
just the old like treadmill test from
yeah.
15 years ago when we were training, where everybody got put on a treadmill and it was like, okay, well, this is worthless, or it had a false, where they're all false positives, et cetera, et cetera. So they are, for what it's worth, much better stressed, sorts of testing that they used to do.
Right, but it would still require some kind of admission to obs or some further testing if we were to believe this versus they can follow up with their doctors. This can happen at some point if their doctors think this is still a problem, if medical management isn't enough, so on and so forth.
Yeah, I mean, it's an interesting article. Like, out of all the articles we've done recently, this is one of the most provocative ones that we've seen that actually kind of almost have to take seriously because of the scale of the numbers. And some of these authors are really, really smart, sharp people. Like Rita Redberg and Ben Sun are really sharp people that I know personally. Not to say the other people on this list aren't sharp, but those two people that I know personally are very sharp. Yeah, it's a very interesting one to digest it yourself. And we shall move on to an entirely different topic yet again. And this is two articles that we're going to kind of cover as a group. And they are a qualitative study exploring adolescent and caregiver perspectives of electronic suicide screening in the emergency department. And then the same sort of title, but also exploring the perspectives and in response to a positive screen. Both articles have the same lead author, which is Rachel Cafferty, and they are at the University of Colorado School of Medicine. Like I said, two paired articles to look at together by the same article and part of the same study. They are obviously both looking at patient perspectives regarding screening for suicidality in the emergency department. The first looking at perspectives on the electronic screening device itself, which replaced their typical nurse-led questions, and the second looking at responses to a positive screening result. These are both semi-structured interviews. The first one, about the electronic screening, conducted 17 interviews, 8 adolescents, and 9 caregivers, following completion of this electronic screening, but with a non-positive result. The demographics of the parents and the children are all over the map, but interestingly, most of those interviewed had an existing mental health diagnosis, both either the children or the parents. The feedback regarding the survey generally included favorable themes. Caregivers were reassured by the fact that their child was getting screening, while adolescents appreciated the privacy afforded by the electronic method. Both groups felt like the survey helped tailor the follow up based on the answers provided. Naturally, this is just a small cross section of the hundreds of non suicidal patients who receive electronic screening. There's no direct comparison to the verbal screening methods, so there's only so much that can be said regarding a single arm study such as this. However, it is reasonable to suggest that this electronic screening method is grossly acceptable. These same authors also surveyed patients and caregivers whose children answered yes to at least one of the passive thoughts of suicide questioning. This is the so called non acute positive cohort, not the acute positives, the ones who required immediate evaluation by psychiatry or institutionalization. This segment dealt less with the electronic screening tool and more with how the emergency department staff responded to this positive screen. In contrast, the 17 caregivers and adolescents screened here provided overall negative impressions of their ED experience. The initial concerns started with lack of consistent responses from emergency department clinicians, ranging from falsely reassuring to no response to a positive screening result whatsoever. When there was a response, concerns were voiced over the timing, the proportionality, and the overall ensuing communication. Finally, the response to the positive screen was generally viewed as non constructive, failing to provide patients with adequate scaffolding and resources for moving forward. I think these two studies together do a nice job encapsulating the difficulties associated with mental health care, especially adolescent health care in the emergency department, let alone health systems in general. There's a huge screening burden in the emergency department for so many things. And yes, the electronic screener may offer a new tool that both unburdens ED staff and provides patients with a safe environment to complete the questionnaire with a degree of privacy and autonomy. However, the second part of the study exposes the fundamental problem. After we've done the screening, now what? What do you do with the domestic violence risks identified? What do you do with the alcohol and substance abuse risks, the fall risks, the mental health risks? The emergency department has strayed so far from its original scope as a medical facility for the acutely unwell to the 24-hour all problem safety net. This type of study exposes the problems with that expectation. The unavoidable consequence of gutting the rest of the health system and relying upon the wrong resource to fill that gap means that people in that resource just simply don't have the expertise or time to adequately address those gaps when identified.
Yeah, I mean, this is example of like, don't ask questions you don't want the answer to, or you don't know what to do with the answer to, right? Because it's like you're exactly right. Like, I think this is mostly a reflection of that idea that a bunch of clinicians got some answers that they didn't know and weren't trained how to deal with.
I mean, we all want to do this best thing for our patients, and a lot of these patients coming to the emergency department, it's really important to make sure that they get linked up with the this mental health screening on face value. It's very important, just like all the other screening we do in isolation. It's really important. But then once you're screening for everything, you just don't have anything to offer these people. I mean, at the same time, you're supposed to be doing whatever opioid substitution therapy. You're supposed to be, referring people on for home-based assessments if they fail, like falls risk assessments, like all these different things. But not every emergency department has the resources to do such a thing. It's just it's basically an unfunded mandate to fill in the gaps that aren't being filled by primary care and other providers.
Yeah, and not only you don't have the resources, you don't have the training, right? Like, that's not what emergency physicians were trained to do, and so they're not gonna be good at it, and you can ask them to be good at it, but then they don't become as good at the emergency medicine that they're supposed to be good at, right? And so, it's a zero-sum game we're playing here, so the more things that we have to deal with, the less we can focus on the things we're supposed to be focusing on.
And it feels very typical for an emergency department to have like one or two champions for these sorts of things, like somebody who really thinks that adolescent mental health is their passion, and they've driven something like this to make sure that we become a safety net for this. But they haven't brought everybody else along with them because they don't have the training, they don't have the time to train, and they also have their own passion projects. And it's just it's a I feel like this is replicated in every emergency department across the country. That there's somebody driving one specific passion project, and everybody else is like, "Oh, I don't have the skills or time to actually do this." But it on face value, it's a good idea, so I'm not going to
Right.
object.
And if you have the resources to build the infrastructure where this can happen without requiring the emergency physicians to become experts in this, then this might be a good idea. But I think most emergency departments don't have those resources.
Yeah. So the lesson here is if you're going to do a screening thing, make sure that there's everything's in place once you get the positive result. Ideally, it doesn't involve a wide variety of emergency clinicians with their varied experience, and actually involves somebody who's a specialist in taking care of that positive result.
Yeah, and I think the bigger lesson that we say every time is we have to stop pretending that we can do everything for everyone all the time and be good at it all, right? The more things we try to do, the less gooder we are at everything.
The less
Um,
gooder.
and, and
I don't speak so gooder anymore
right,
either.
exactly. So the idea is like we just lose our ability to be good clinicians when we spread ourselves so thin, and it seems every step emergency medicine is making is to spread ourselves more and more, and try to do more and more because of the broken system we're existing in, rather than saying, "Hey, stop! Wait a minute. Maybe someone else should take this burden."
I should just add it to the list of alerts that we have to respond to. Stroke alert, STEMI alert, sepsis
Yeah,
alert, mental health alert, you
yeah.
name it.
Eventually,
All
it
right.
just alerts.
Situational aggression score alert.
Yeah, yeah. Speaking of screening tests, we have another one. So our next article is implementation of the dynamic appraisal of situational aggression DASA score in the emergency department triage, and the lead author is Amy Costigan. So this is the idea that obviously anyone who works in the emergency department has been placed with workplace violence, where patients, because of the situations they're in, the mental health problems they have, so on and so forth, act violent to the staff in the emergency department. And this score is intended to maybe provide some predictive value in identifying which patients are at higher risk for the self and the staff, and so that we can, earlier identify and potentially prevent some of these outbreaks. So this score originally was derived and validated in the psychiatric setting, but there really isn't really any data on how useful it is in the emergency department. So these authors set out to establish some evidence, and they conducted a descriptive study of 5 emergency departments, 2 academic, 3 community centers, through January through December of 2023. And essentially, all patients who presented to the ED at triage during that year had this screening score done to them by the triage nurses. The score itself takes 7 behavioral indicators: irritability, impulsivity, unwillingness to follow directions, sensitivity to provocation, anger when denied requests, and negative attitude and verbal threats. And the score is a 0 or 1. You get a total score of 0 to 7, 0 being low risk, 1 to 3 moderate, 4 to 5 high, 6 to 7 imminent risk, or in your words, the red wind warning. So they basically pulled these scores electronically. There was no manual chart extraction, and they looked at the distribution of the DASA scores across demographic groups and compared characteristics of patients who were scored and those who were. So over a 12-month period, they screened a whole lot of patients, over 192,000, and about 80%, over 159,000, received a DASA score. So pretty good screening. 94% of these encounters were low risk. So the vast majority of them had a score of 0. About 4.5 had a 1 to 3 of moderate risk, 0.8 had a 4 to 5, and 0.6, about 1,000 patients, had imminent risk or a red wind warning. So only about 1 in 100 patients were deemed to have imminent risk of aggression. People with high risk scores were more likely to be men. Younger age correlated with higher scores. The acuity at which a patient presented, so patients with an ESI score of 1 or 2, had a higher likelihood of being in imminent risk. Arrival by the police, not surprisingly, also had a higher rate of imminent arrest. They also noted from racial differences, Black patients were far more likely to have a high risk score, while Asian patients were underrepresented in a much lower score. Honestly, I'm not exactly sure what to do with this. I guess it shows that this can be added to a triage nurse's duties, and it can be done reasonably well. They didn't actually determine whether these scores actually predicted any risk of violence with their patients. So it's pretty unclear how useful this was that of actually predicting patients. And of course, the most important, they didn't compare it to just our clinical gestalt of seeing someone in triage like, oh, they look like they're about to get angry, right? And so again, I guess this shows that it's feasibly possible to calculate the score, although we don't know if it has any predictive value the way it was done.
I mean, I think that's the key, is that this score is not designed for use in the emergency department. It was never derived or validated in emergency department patients. Even when it was derived and tested in the settings in which it was, which was in a mental health unit, looking at violence over the next 24 hours of their inpatient mental health stay, the
Well, to be fair,
prevalence of
that's a short
aggression
stay
is
in the emergency department.
yeah. But the prevalence of aggression was really, really tiny. And the performance of this score, like it's some of these some of the validation articles are like sensitivity of 60%, specificity of 70%. It's not that much better than a coin flip. And then you have this article saying, "Oh, it's a score that takes less than 120 seconds to complete," and I'm like, "Well, so that's 2 minutes per patient times 200 plus patients per day on your triage nurse, that's an entire nurse's shift worth of work, almost, to some like,
And then what are you going to do with it? Someone's high risk. We have no validation whether that actually means anything. What are you doing to that patient, right?
mental
All of
health
a
alert
sudden,
overhead.
yeah,
Ding, ding, ding.
all of a sudden we're like persecuting a patient that might have done anything wrong or wasn't. This is almost like Minority Report, right? We're like committing these people to crimes they haven't committed yet.
Yeah, and everything. I think the scores by ethnicity portion, that's obviously very concerning, to put it mildly. We don't know much about that. I mean, yeah, we're a long way from being able to deploy a score like this. I mean, maybe it is better than a person's in like like current unconscious biases, but they don't really compare it to that.
It doesn't.
And
Yeah, it
without
might
any
not be.
data, like, yeah, don't do this until there's a lot more data backing it up and
And
describing its utility and actual implementation in an
right,
emergency department setting
that's the
and
key.
its
I think
value. Like,
you
it's
have
like
to
there's so
really
much, we're
think.
missing so much data here, other than
Yeah.
the fact that you can do it. That doesn't say anything about whether it's good to do it.
And
And I would
even if
assume,
it has some predictive value, you need to think really hard on how you would deploy this, right? Because it can be incredibly unfair and alienating to patients who are obviously already having a bad day.
it's just some PRN droperidol on the order set. Everybody.
Not even a PRN, it just automatically gets ordered.
It's in
Yeah.
that first bag of fluids, like it's 0.9% normal saline with 1.25 of droperidol added.
We
That
joke,
sounds
but
like a great
obviously
fluid resuscitation bag, by the way.
yeah, 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 yeah. I think that wraps us up for another month.
I like that idea. They should have
Yeah,
a pre-mixed bag with droperidol in it.
I think the problem the
Just
problem
bolus
with that is
everybody.
it just doesn't
We
go in
call it
fast
the D
enough.
bag.
We are getting way off. We're definitely gonna get some comments or concerns this month.
I have not said anything inappropriate or offensive.
I think the big problem with that is it won't go in fast enough. You can't run your fluid in fast
Oh,
enough
you don't want to get dystonic reactions. Infusing that droperidol over an hour is fine.
All right. Well, I think it's important for me now to say, with any comments, questions, or concerns, we can be reached at annalsaudio@acep.org. Otherwise, until next time, this was Rory Spiegel and Ryan Radecki, and this was the Annals of Emergency Medicine podcast.